and I believe there's 1 credit attached to this. In the invite that we sent out initially, there is a link, so that way you have the same link that I'm showing here. You go in, put your name in, and then this ID number. If everybody can remember to put your phones on mute so that Dr. Dhar doesn't get any feedback when he's speaking. And I will turn that over to Michelle to do an introduction for us. Thank you for your patience today.
Yeah, thank you, everybody. Sorry for the technical difficulties. So I'll begin my introduction. So easy access to advanced cardiac care. That is our team at Nazareth Cardiology. Our team of experts include Dr. Thomas Metkis, Sunil Dhar, Dr. David Adley, Federico Viganigo, and of course our man of the hour, who was our interventional cardiologist, Dr. Sunil Dhar. Dr. Dhar received his medical degree from Saurashtra University in India. From then, he went on to complete his residency, where he was chief resident at Temple University Hospital in Philadelphia. Prior to his fellowship onboarding, he was an internal medicine practitioner at both Temple University for 3 years, as well as Drexel for 2 years. He also served as an associate professor. He received his fellowship at the University of Washington, Seattle, for advanced heart failure and transplant, and the University of Minnesota, Minneapolis for interventional cardiology. He is board certified in internal medicine, cardiovascular disease, interventional cardiology. And to add some color to his bio, so under Dr. Dhar's leadership as the medical director of the cardiac cath lab at Nazareth Hospital, he truly has brought new depth and breadth to the cardiac program. We're now offering a new state-of-the-art cardiac cath lab partnered with Philips Healthcare, who is the market leader, providing high quality imaging with low doses of radiation for patients of all sizes. He and his colleagues are now able to conduct minimally invasive procedures on this new system to treat a wide range of clinical problems, including coronary disease. The benefits of catheter-based interventions include shorter hospital stays, reduced recovery time without the pain of a large incision, and less visible surgical scarring. I feel like I'm serenading you verbally. He has also introduced Impella to our patients with severe coronary artery disease, as well as defibrillator implants. Dr. Dhar is also an accomplished author with publications in many medical journals. I found that while trolling on his LinkedIn profile, which is quite impressive, by the way. He is also championing to get a cardiac fellowship with his colleagues here at NAS, and Corazon results came back yet again very positive and favorable. So with that concludes my introduction, and Dr. Dhar, take it away.
All right. Thank you, Michelle. And that was like too long of a presentation. I don't know. Who's controlling the, you guys?
Introduction.
So.
Dr. Dhar, it's Nicole. I'm controlling it, so you just let me know when you want to go ahead.
So the objective of today's talk is to talk about basically primary prevention and a bit of secondary prevention of coronary artery disease with the antiplatelet agents. So these are the objectives which we'll try to learn about therapy, antiplatelet therapy in management of coronary artery disease. We will try to review what are the current guidelines in management of CAD and with antiplatelet agents. And in between, I will try to fill in with some literature which is current about antiplatelet use in people who have coronary artery disease. I will try to make it short, not to bore you with data, which is kind of boring, and basically it should be like, what's the punchline here? That's what my goal here is. All right, next slide. So we know that heart disease is still the #1 killer in the United States, and actually most of the Western world, 7 million people still die in US from CAD, and more from its effects like heart failure following coronary artery disease. And the way we have been traditionally told to prevent CAD is prevent aggregation of platelets around areas where atheromatous tissue actually builds up by multiple risk factors, like people who have hypercholesterolemia start depositing lipids in their endothelium, and eventually if there is an issue with that plaque, which is highly dense with lipids, it exposes that lipid core to the blood, and platelets get attracted to it and start clumping there and causing a clot within the coronary, and that becomes the pathophysiology of acute coronary syndrome, and people come with heart attacks or unstable angina or ST elevation MIs. So platelets can play a role in preventing that and preventing events from coronary artery disease. Next. Obviously, if you inhibit those platelets, traditional thinking is that, let's go back, that we can prevent these issues of thrombosis within the coronaries or other vascular beds and then cause relief of the symptoms as well as better outcomes in long term. Next. So aspirin, all of us know we have used aspirin forever. It is in every medicine closet, I guess, in this country and worldwide, actually. Surprisingly, aspirin has been used for last 5,000 years. The earliest descriptions of aspirin comes from Sumerians and Egyptians, and actually an Englishman by the name of Edwin Smith went from England in 1862 and went to Cairo and somehow got these papyrus documents, which were, I don't know where he got it, but he claimed that he got it from legal sources without any provenance of those. And eventually those actually describe various procedures, surgical procedures or fracture reductions. But one of the paper actually talked about a medicine or a potion which was gotten from the willow tree, from the weeping willow. And that thing was given for people who were suffering fever and aches, the extract of that weeping willow. Eventually down the line in 1862 and eventually in 1900s, a German scientist along with a clergyman, an Orthodox clergyman, actually won a Nobel Prize for actually having aspirin as an antipyretic agent. Since then, aspirin has been used for every single ailment, actually, at different times in different centuries and different decades since the World War I. What we know now is that aspirin irreversibly, inhibits acylation to an active site of COX-1, which is required for thromboxane production. As you know, thromboxane is important for platelet aggregation. It acts like a glue where platelets actually stick to it. So if you somehow actually block that mechanism by blocking the COX-1, platelets won't aggregate and thrombus will not form. And this effect is seen at any dose, as low as 30 milligrams, as high as 1,000 milligrams, and all of these doses have been used in the past and currently for that antiplatelet effect, blocking the aggregation. Higher dose of aspirin can also block COX-2, which is a different enzyme, works at a different level in that prostaglandin cascade, and that then causes antipyretic or analgesic effects. So that's why aspirin can work in headaches and fever, and it can work in heart attacks too. Next slide. Now there is recent evidence that there is some effect of aspirin in cancer prevention, especially colon cancer prevention, by having effect on apoptosis. I'm not going to, spend time on that because that's not my, wheelhouse. So I'll stay where I am in coronary artery disease. Next slide. So the biggest question, which always kind of, is there, who should we give aspirin to? There was a time when people were talking about polypill. Basically, they were saying that anybody who has hypertension, diabetes, let's put some amlodipine in that, let's put in some cholesterol medicine in that, and let's put an aspirin in that and make a pill and give it to everybody who has risk factors. And we had a polypill like that for some time, and it didn't work very well as far as outcomes were concerned. So those were stopped. Since then, we had multiple kind of, trials and databases which have looked at the role of aspirin in preventing ischemic and stroke events. Okay, next slide. So from day one, if you look at traditional thinking, we would have said, hey, aspirin, just take it instead of pour it in water and eat it with lunch, and you would be good because that will prevent an event for you, especially in heart attack. It was sold as if you don't give aspirin to anybody, you will certainly have a heart attack in future, and you can prevent events like the second cartoon talks about is bypass surgeries in people. Now we are at a time when we don't know what to do with aspirin. Most people, are worried about giving aspirin and bleeding and worrying about lawsuits with that. And as you can see, the third cartoon says that we should probably get an MRI or a CT scan of the whole body rather than giving an aspirin. So where we are with aspirin for primary prevention, it is still kind of out there. I will show you some data about what currently the guidelines say and where does that information come from. Next slide. So this is quite a busy slide. Is there a way I can, Michelle, have a pointer? Sorry, Nicole, point to the slide. Okay, so you control it or I control this?
I think I have to since I'm moving your slides for you.
Okay.
Sorry.
So as you can see, this is a combined data of most aspirin trials which have been done. There are like 13 randomized controlled trials in this, total of 195,000 patients in this data. Well, if you look at the left column, it talks about mortality, myocardial infarction, strokes, bleeds, or cancer. So what kind of data do we have about each individual effect as far as aspirin is concerned? The level of evidence we have is in the third column, the certainty of the evidence. We go from low evidence to high evidence. The high evidence we have is in heart attacks, that's myocardial infarction. You can see 4 pluses to it, and bleeding. So we know it can prevent heart attack and it can cause bleeding too. So we have a lot of evidence for that. Everything else we have maybe some or not some at all. Mortality, we don't know, it causes some mortality versus rectal cancer prevention, some effect. The most important part of this slide is to look at the right extreme column, what it says risk difference with aspirin over 10 years. If you look at the total mortality, you will prevent 2 deaths if you give it to 1,000 people over 10 years. So you have to treat 1,000 patients with aspirin every day, and you will prevent 2 deaths, overall deaths. And if you go down the list, you can see you can prevent 5 heart attacks in people who have low risk, 14 heart attacks who have moderate risk, 23 heart attacks who have severe or high risk of having cardiovascular events. So it looks like that the numbers are not kind of overwhelming. 5 out of 1,000 is not a huge number. It's 0.5%. Obviously, if you have a lot of risk, then you will have better, like maybe 2.3% prevention, as you see 23 fewer deaths in 1,000 patients over 10 years. What we also want to see in the bleed section, if you look at the major extracranial bleed, that's the fourth box, you will see you will get 4 bleeds. So you'll prevent 2 deaths, but you'll get 4 bleeds. So you'll have more bleeds and less prevention of death. You will have 11 bleeds in moderate population versus high risk population, you will have 18 bleeds. So a lot of people bleed on aspirin, a benign 81 milligram aspirin, which is sold on all the counters, over the counter medicine. Next slide. So people have doubted about the utility of aspirin in primary prevention for a long time. And as I showed you, the data of 195,000 patients from 13 trials showed that aspirin use is nebulous actually in primary prevention. And then came 2008, and that was a real barrier for aspirin. If I was an aspirin believer, I would be like holding my head at what I have done all these years. Next slide. The reason why 2008 was a bad year, because that year there were 3 large randomized controlled trials, which we believe is the gold standard of any kind of, evidence-based medicine. Those were published. They were Ascend, Arrive, and Aspirin. Now, I'm not going to bore you with all the details. They were, as you can see, they were published in New England Journal of Medicine. They were published in Lancet, major impact journals. The first trial, the Ascend, was a trial which was especially trial designed for diabetics, because we always fear diabetics have worse outcome. They took about 15,000 patients. Now the trials are also kind of separated from each other in a way that Ascend was a trial of people who had low risk, that is a Framingham risk score of less than 10% over, over next 10 years, or sorry, 5 years, versus 15%, which is moderate risk in Arrive, and more than 20% in Aspirin, which is high risk patient. So in essence, patients who have diabetes and don't have any previous cardiac event, if you give them aspirin 100 milligrams or less over the period of 5 years, you will not actually make a significant difference in their mortality. That's basically what it is 9.7 versus 10.2. So there is about 0.5% reduction, which we already saw in the earlier data which I showed you. So 0.5%, you will save 5 deaths in 1,000 patients over a period of 10 years, but the bleeding is more. Then came Arrive, which had around 12,000 patients in it. Those are the patients who have never had a coronary event or a stroke. They did not have diabetes, but they had moderate risk. That is 15% risk in 10 years as per Framingham score was concerned. Again, same thing, gave 100 milligram aspirin every day to placebo and tried them for over the period of 5 years. You could see the risk of death was 2.5%, 2.55% in people who were getting aspirin, and 2.57%. Basically, it was a wash, no benefit. Then we went to higher risk patient. It is not 9,000, it's 19,000 patients actually they took who were 70 years and older. So what happened in these patients when we followed them for 5 years, out of them, risk of death actually was higher by giving aspirin, 12.7% versus 11.1%. So more issues by giving aspirin in people who are 70 years and older. So what you gather from these 3 large trials with randomization of around 45,000 patients with aspirin 100 milligrams or less over the period of 5 to 10 years, there is no clear signal that aspirin actually prevents anything except for headache. Next slide. Next slide. All right. So this was about all-cause mortality. I was talking about whether it prevents death or not. It didn't matter what death. Okay, now we say maybe it prevents only cardiac death, right? There was, again, some data about that in 2016 with meta-analysis of multiple trials of around 135,000 patients. I will show you that study later on, which actually showed that aspirin use does benefit. It does cause decrease in heart attacks, 22% relative risk reduction to 0.78 with a very tight confidence interval where the CI is below the line of unity for those who understand that part of the statistics. I can actually talk about that in a few other slides. But then once you look at the data from Ascend, Arrive, or Aspirin, you will see that the rate actually does show that it is benefiting. It is 0.98, 0.85, or 0.93. So there is decrease. But the problem with all that data is that if you look at its confidence interval, it crosses line of unity. That means that if your CI is more than 1, it could be anywhere. That means you may or may not have a benefit. The chance of decrease is purely chance-wise. It's not ascribed or given to the fact that you actually took aspirin. If you were not taking aspirin, you could still have that benefit. So obviously did not work. Especially in aspirin, there was more hazard. People had more MIs if you were giving them aspirin without a reason to give aspirin. Next field. Next slide. So what's the summary of aspirin from the primary prevention perspective? All-cause mortality, no impact. There is high quality evidence. That means there are 45,000 patients in 2018 from randomized controlled trial that showed that aspirin does not decrease all-cause or cardiovascular mortality. How about non-fatal myocardial infarctions? There's likely reduction, but the evidence comes from mainly from the data which is non-randomized, and there is a lot of bleeding associated with it. How about stroke? There is no reduction. Again, the same theme. I will show you some data later on about stroke and aspirin. So the evidence is okay. It's not the best evidence. I will skip colon cancer, but there is very low quality evidence that colon cancer can be prevented by using aspirin alone. Next slide. So who do we give aspirin now then? Should we give at all? I'm just telling you that aspirin doesn't work completely. But there is a category, if you look at the subgroups of all these trials, people who have risk, that means they have risk of more than 20% of having a cardiovascular event over the period of 10 years, you may benefit from aspirin. So that is why if you ask most experts who to give aspirin, they will say give aspirin to anybody who is in between age 40 to 70. Those patients, among those who have a Framingham risk of greater than 20%, or those who have familial hypercholesterolemia. These are the people you can give aspirin. Before you actually give aspirin to them or decide that I want to prevent aspirin, first you should look at their bleeding risk. So for primary prevention, always first think about bleeding and then about prevention of coronary artery disease. If you believe that there is more risk of bleeding, then I think you already know that aspirin is not a good idea. Next slide. So this is about the CVA prevention. Again, data from Ascend, Aspirin, and Arrive. You can see that the hazard ratios are very close to 1, and the confidence interval travels between 0.73 to 1.06 in the first trial, to the last where it is 1.7 to 1.1, always crosses the confidence intervals. So not good, reliable data. So we should not be even banking on that. Not good for primary prevention of CVAs either. Next slide. Here's what the American College of Cardiology and American Heart Association says about use of aspirin. It says that for primary prevention of cardiovascular disease, you can give aspirin 75 to 100 milligrams daily in people who are aged 40 to 70 and who are at higher risk of cardiovascular disease, but they have to be at a lower risk of bleeding. So you have to first figure out bleeding risk. And low-dose aspirin should not be given on a routine basis for primary prevention of cardiovascular disease among adults who are 70 years or old. We saw that because it causes more death. So aspirin is not a good idea for people who are old for primary prevention. Next slide. So if I was on the aspirin camp, I'll be thinking, what the heck? Why am I giving an aspirin talk? Is there any good news about the aspirin? And as this cartoon says, well, there's no more bad news. That's enough for a good news for now. Next slide. Well, the good news is secondary prevention. That means those people who already had an event, whether they had a stroke, whether they had an MI, or such kind of episode, aspirin may have a role. The largest set of data, which was compiled in British Medical Journal in 2002, is called the Anti-Thrombotic Trialist Collaboration. Next slide. This is 145,000 patient data from multiple trials, sorry, 135,000 who are high risk. And the bottom line of this data, next slide, next, is this one. So if you look at the trial, look at the picture where there are the dark boxes, and you see a dark line coming in the center. Dark line coming in the center of the blue box. Can you point towards that? Yeah. All right. So that is the line of unity. So when you devise any trial and you want to have positive effects, the odds ratio should fall on the left side of the line. Okay, that's number one. So you can see all these trials with their effect, each effect. You can see those boxes, black boxes, falling to the left. So they work. All of them work fine. In primary prevention, it works. The second thing you want to see when you look at the trial and odds ratio is that box traversing to the right at all, ever. So if it does go to the right of this black solid line, that means the confidence of that trial to have that effect is not enough to call it a true effect. So the breadth of that black box is the confidence interval of that data. So as soon as it starts traveling towards the right side of the solid black line, data is no good. As you can see in secondary prevention, all of these categories of trials which looked at previous MI, people who have acute MI, people who have previous strokes or acute strokes or other high risk things like PVD, it did work. Aspirin did work in various doses. So that's the data from this collaboration. Next slide. Next. So from this, we know that patients who have acute coronary artery syndrome, such as MIs, unstable angina, you should give aspirin. The doses are again anywhere between 75 to 600 milligrams. There's data for all of that. Patients who have acute occlusive stroke, obviously you have to give aspirin. We all know that. Patients who have stable coronary artery disease, including those who had previous revascularization, either by coronary artery bypass grafting or by stenting, or those who had PAD or carotid artery disease, all of them have been shown, as I showed you in the previous slide, that there is benefits. Odds ratio is towards the left side of the line of unity. Next slide. So that's about aspirin in brief. So aspirin primary prevention, thumbs down. Aspirin secondary prevention, thumbs up. You should give them. Okay. A lot of people got excited when these agents like P2Y12 inhibitors came into existence. That is in early 2000s. We know these drugs. All of you guys have used these drugs. Like the first one, which was on the scene, was clopidogrel or Plavix, and then we had prasugrel or Efient, and the third one is ticagrelor or Brilinta. All of them work in secondary prevention. Two of them, Plavix and Efient, which it means clopidogrel and prasugrel are prodrugs, while ticagrelor is a directly acting drug. All of them were given orally, while prasugrel and ticagrelor are fast acting. Clopidogrel will take about up to 6 hours to work, and they can stay in the circulation for a long period of time. The reason why clopidogrel and prasugrel stays around for 10 days versus ticagrelor is there only for 3 to 5 days is the fact that clopidogrel and prasugrel are irreversibly binding to platelets. That means they will stay and inactivate platelet for the time of the life of the platelet, which is around 7 to 10 days. For ticagrelor, it's a reversible agent, so it actually leaves the platelet after 3 to 5 days. So the same platelet which lives for another 5 days may be able to help to cause thrombosis. So in people who need to go to a procedure and you want to give an antiplatelet agent, you should rather give them an agent which is reversible and will decrease the time of wait for the surgeries, especially true for people who are getting a bypass surgery. If at all you have to use ticagrelor because they may be able to, or some other surgery. The fact is that if you're using it and how many days you want to stop it prior to surgery, that's the way you will decide that if the patient is on Plavix or patient is on Efient, you will have to wait 10 days before the surgery can be done. If the patient is on Brilinta, you will wait for 5 days and the surgery can be done after that. The doses of loading and maintenance you all know, and withdrawal before surgery is written down there. Okay, next. Now, some smart people from Brigham and Mayo, they thought that, well, aspirin did not work for primary prevention. How about if we use these stuff? Maybe aspirin was not strong enough to prevent platelet aggregation. Maybe we should put in a little bit of Plavix or a little bit of Brilinta, a little bit of prasugrel, and make it stronger potion, and everybody's platelets will be knocked off and they won't get MIs or ischemic events. So they looked at that for stable CAD. Let's see what happens in that. Next slide. So the largest first trial to see whether combining aspirin versus plus a P2Y12 inhibitor will work in comparison to aspirin alone was Charisma. It was, you'll see Dr. Deepak Bhatt, who is now at Brigham. He used to be at Mayo that time. So you will see him time and again in all these platelet trials. So they devised this trial of around 15,000 patients, followed them for about 2 years or so. They gave them, Plavix and aspirin, and looked at their outcomes. Outcomes were ischemic events. Bottom line was that there was more harm. There was more bleeding. Nothing happened to platelets, which tells us that the platelets were already knocked out by aspirin. So it was no more benefit from platelet inhibition, but there was definitely more bleeding. Next slide. This is the graph which shows the end result. Death, MI, and stroke is on the y-axis. X-axis shows you months since randomization. You will see that Placebo, that is aspirin and placebo combination, the event rate was 7.3%, while with clopidogrel and aspirin it was 6.8%. Again, that 0.5% drop. Remember that. But to decrease events of death, MI, and stroke by 0.5% in a high-risk population, you are increasing bleeding by 1.8%, which we saw 18 bleeds per 1,000 over 10 years. So you'll have 18 major bleeds on one side who get aspirin, Plavix, and on the other side you have less. While those people who get aspirin and Plavix, there will be 5 less heart attacks, deaths, and strokes. Next. So it did not work. And the same group of guys came up. You can see Deepak Bhatt again said, well, why don't I try ticagrelor? Maybe that'll work better. All right. So they did the trial again. It's called THEMIS. 20,000 patients. Looked at them for about 3.5 years. Gave them aspirin and ticagrelor, and looked at their endpoint was death or a stroke. What happened at the end? Next slide. You can see the blue line is ticagrelor, while the red is aspirin alone. If you look at from a distance up to 54 months, it doesn't look on any different. It looks like they're overlying each other. But if you zoom into the end part of the line, then you can see that the placebo actually separates from ticagrelor. That means that the events of incidence of death and MI is less with ticagrelor and more with aspirin alone. P-value was 0.04. That tells you that the primary endpoint had statistical significance, that if you use aspirin and ticagrelor, you will have less events in people who have stable coronary artery disease. However, next slide. Look at what happened to bleeding. You increase the bleeding by 2.32 hazard ratio. People who had aspirin alone, bleeding was less. Ticagrelor, lots of bleeding. Tons of people started having intracranial bleeds. So it doesn't work. Another few $100 million waste. Next slide. By the way, each of these trials cost around $100 million. So you can see that because the business end of it, people are interested in pushing these agents, but it did not work. Now we know that these agents do work. They do work in ACS. I'm going to talk briefly about a couple of trials about acute coronary syndromes, which include people who have unstable angina, non-ST elevation MI or STEMI. So these agents do work. The first data set which was available to see that in a randomized fashion was from Cure trial. I'm not showing you here that's 20-year-old trial with clopidogrel. It showed that, yeah, Plavix, when you give after PCI, it will work. It will decrease the event rate. The event rate was basically myocardial infarction, non-fatal MI. So you will decrease MI if you give somebody Plavix after putting a stent in or after doing a coronary artery bypass grafting for some period of time. Now we got better. After 2008, when we got these other agents like prasugrel and ticagrelor, we devised more trials and see if we can get better benefits. The first I'm showing you this trial called Plateau, which is with ticagrelor plus aspirin versus aspirin alone in people who got PCI for ST elevation MI or non-ST elevation MI. Large data set, you can see that there was a decrease of 2% in absolute numbers of mortality, MI, death. The biggest thing about this trial was this was the only trial since the advent of aspirin, which we know causes decrease in all-cause mortality. This is the only drug after aspirin which decreases death. All other antiplatelet agents, which include like previously those who have used ticlodipine or dipyridamole, which was used to be an antiplatelet agent, it did cause decrease in MI, but never decreased death. So ticagrelor in current day era is the only medicine in antiplatelet world which decreases death by around 2%. Next slide. But it comes at the cost of bleeding. Bleeding was still acceptable. It was high but acceptable. Therefore, we still use ticagrelor. Me personally, I exclusively use ticagrelor. Not that the prasugrel doesn't work. This is the trial which came actually before ticagrelor, a year and a half before ticagrelor, called Triniton TIMI 38 trial with prasugrel versus clopidogrel in patient with acute coronary syndrome. Same, you can see that 12.1 to 9.9% is the effect size That's the drop of around 2 to 3% you will get from the event. So you can use that, but the problem with prasugrel is that, number one, if you are a purist, you will look at the trial, how they used it. They wanted to see the anatomy first. They did an angiogram first, looked at the coronaries and saw that whether they can actually use a drug or the patient is going to surgery. If the patient is going to surgery, they will not use prasugrel. We would like to use the drug without knowing what the anatomy is. So the next part of the problem was with prasugrel was there's a black box warning about it now that you can't use in people who are 80 years or older or those who had a previous CVA within 6 months. So sometimes when people come in with an MI, we don't have time to ask them a detailed history. So when am I going to ask him that you had a CVA or not? So should not be giving it unless you're 100% certain about those things. But it does work. It does not decrease all-cause mortality, though. Next slide. So what are the guidelines about P2Y12 inhibitors? You can see on the left side, there's European Society guidelines, and we'll focus on the AHA guidelines on right side. Now, in all patients who have acute coronary syndromes, we will give 12 months of dapt, which includes aspirin and probably one P2Y12. In Europe, ticagrelor is preferred over clopidogrel, irrespective of the initial treatment strategy. In America or United States, we say that it is reasonable to prefer, but it's not mandated to use clopidogrel instead of to use ticagrelor instead of clopidogrel, especially after stent implantation. Now, clopidogrel has a clear lead over ticagrelor and prasugrel in patients where fibrinolysis has been done. If you are treating somebody somewhere with a TPA for MI or a TPA for CVA, you cannot use Brilinta or prasugrel. You will have to use clopidogrel. That's the only data which is available. So prasugrel is recommended over clopidogrel in patients proceeding to MI, PCI or in patient with STEMI undergoing immediate coronary angiography. That's the class 1 recommendation as per European Society guidelines. And again, it is reasonable in America to prefer it over clopidogrel for the same reason which we talked about. And it also says that you have to be careful about stroke, bleeding, and TIA in the past. And the last portion of that is that clopidogrel is recommended in patients with fibrinolysis, which I already told you. Next slide. So somebody got an MI and we put a stent in or had an unstable angina event or an ACS, and we are on board with aspirin and either Plavix or Efient or Brilinta. The question always comes, what's the rationale? How long? Which agent? So those are some questions. We know that there is enough evidence. I can show you that, hopefully I have time, that it is better than monotherapy. It decreases the risk of stent thrombosis. The problem with stents is that once you put a stent in, there is metal which is exposed to the blood, which is circulating the coronary arteries. It takes around at least 12 months for that stent metal portion to get endothelialized completely, so that then blood is not in contact with any metal. When that happens, probably your risk of having in situ thrombosis is as good as somebody who has normal coronaries. Before that, you have high risk of thrombosis because of platelet aggregation, so you need stronger platelet inhibition. That's why dapt works in those scenarios. Next slide. Now, which agent to use? There was a head-to-head comparison between prasugrel and ticagrelor in about 1,000 patients who were treated with a stent because of MI. The study was actually stopped prematurely because there was no difference in outcomes. The outcome was 4% with prasugrel and 4.1% with ticagrelor, so no difference. So it doesn't matter what you use as long as you use something to prevent in-stent thrombosis. Over the period of long term, again, more than 30 days after the PCI was performed, still there was not much of a difference between these agents. So we don't have an answer which one is better. Next slide. So what do guidelines say? I'm going to just skip this slide. It says that you just have to treat for 12 months with dapt for long term. There is now coming up new data which shows that, hey, we can decrease it to 6 months, especially in those patients where ischemic and thrombotic risk is low. You have to do some kind of decision making about that. What happens after 12 months? We know for now we are going to treat everybody for 12 months. Should we after 12 months stop aspirin? Sorry, a second agent like clopidogrel or many people do that without putting a lot of thought into it. Some of us, especially who do put stents, we think about it. Should we stop in everybody or should we stop in some people? If you look at the guidelines will say if there's no major risk of bleeding, you should continue it up to 36 or 30 months. That's up to a couple of years or 3 years. The way you will know is to calculate the risk score of bleeding. For dapt, there is a separate risk assessment tool called a dapt score. Basically, it's the same score. It's the same risk factors you look at. And if your score is more than 2, you can continue actually, for a longer period of, less than 2, you can continue 12 months and you can go on then for 30 months with a lower dose of 60 milligram of ticagrelor and stuff like that. So yes, so 30 months if your risk of bleeding is low, 12 months if your risk of bleeding is high after 12 months. You can look at the scores. Next slide. The last question I want to tackle is what happens if you are on anticoagulant, like you're on warfarin, you're on Xarelto or Allcause, which is apixaban, and now you are on MI, you are on aspirin, and you're on Plavix. What do we do? Again, there is a lot of data which is recent, actually, some from 2019. We have some insight about that we can actually shorten the duration of antiplatelet therapy. If you look at the recommendations, there's not a guideline statement about that. It says that you can actually stop dapt after 7 days unless there's a major risk of ischemic event. That means in interventional cardiology, there's a large thrombotic burden when you're doing a stent. You can actually stop the second agent, or you can drop aspirin, keep Plavix only, and then start back your warfarin or other agents. The risk of bleeding is more with warfarin as compared to newer or DOACs, which are recommended if you're using only one antiplatelet agent and an anticoagulant. Next slide. So this is basically what I was telling you. This is the same stuff. So you got to be careful when you're using warfarin, because warfarin has wide range of fluctuations with what we eat and what we drink. So that you have to be careful. You can actually choose clopidogrel for long term in these patients. Next slide. Next slide. All right. So I'm going to stop here because we have another 10 minutes. If there are any questions, I will answer those. This is what we get from my presentation today, is that you can give aspirin for primary prevention in people where risk of bleeding is low, especially in people who are 40 to 70 years old. If they're old, you've got to think seriously about giving aspirin to anybody. There's no benefit of dapt in primary prevention, so nobody should be giving Plavix or clopidogrel or plus Affiant or ticagrelor for primary prevention or adding it with aspirin. There's no role. There's definite role of lifelong aspirin for secondary prevention. I showed you the data from antithrombotic trialist collaboration, and dapt is indicated for all patients who had an MI or had a CABG with a recent ACS even for up to 12 months and longer depending on the bleeding risk. Next, I think that's the last slide I have. Questions?
Could you comment in our lab, since we do not do CABG and open heart surgery, the preloading of a patient with acute coronary syndrome or a non-STEMI with antiplatelets, not knowing the anatomy, the potential that they may need CABG, and the subsequent need for delay of CABG. What's your recommendation regarding preloading with antiplatelets prior to the angiography?
So acute coronary syndrome is a mixed bag. It's not one disease, right? It's unstable angina. It is a non-ST elevation MI. It's ST elevation MI. So each of them have different merits of doing dapt upfront versus knowing the anatomy. As I said, if you're a purist and you're looking at somebody who's going to use prasugrel, Prasugrel in Anatomy 38 was not used before you knew the anatomy, what you're dealing with. And if the patient was going for cabbage, they would not use it at all. Ticagrelor, on the other side, they used it up front in the ED for patients who had ST elevation MI. Now, people who have non-ST elevation MI, and if you're planning to go for intervention, the data is weak that you should use DAPT up front. The data says that you should know what you are going through. If at all you are going for a non-invasive management, that means you're not planning to send him to the cath lab at all at any point of time, you should avoid using a DAPT, whether it is clopidogrel, whether it is ticagrelor, whether it is prasugrel. So the data about that is weak. So you should be thinking hard before putting other antiplatelet agent on somebody if you are ever thinking that this patient may hit a cath lab in a few days. That was Dr. Metkus asking the question, who's sitting with me. Any other questions?
So Dr. Dar, I have a question, it's Nicole. And you were talking about patients who in the past have been placed on aspirin, but then the study showed that aspirin may not be beneficial except for those high-risk patients. So if a patient was of the theory in the past that, we place patients on aspirin and now they're, in that age period of 40 to 70, and it was just one of those things that we did thinking it was beneficial, should we start to change that and have those patients stop taking the aspirin at a period of time?
Absolutely, because as you saw that, there is going to be bleeding episode with that aspirin, because as that person grows older and he has a fall or bumps, he will have bleed somewhere. The problem is not bruises, which all of us who prescribe aspirin see quite often. The problem is the intracranial bleeds or fatal GI bleeds. So if there is no benefit, you can stop. Although it is hard to convince a patient who has been taking aspirin for a long period of time without any need of that, telling him that, hey, now we know that for the last 3 years, the data is that you should not be taking aspirin. But I will try to do that and try to prevent bleeding episode in this patient.
All right, are there any other questions for Dr. Dar?
Dr. Dar, it's Wayne. Would you be able to make any comments about the use of aspirin after valvular surgery, mechanical and bioprosthetic?
With the valvular surgery, if you look at the data, if you're talking about surgical procedure or you're talking about TAVR, so with TAVR, there is some data to use aspirin following surgery, following transcutaneous, valve. So the data, again, is not specific to randomized to that said that using aspirin versus not using, but all these patients who had TAVR, they were on aspirin for some period of time. So does that actually qualify them for having a long-term aspirin? No, unless they had a coronary disease, which was also documented at that same time.
Thank you.
All right, any other questions for Dr. Dar? All right, well, thank you everybody for joining today. We really appreciate you coming in, Dr. Dar, and giving us this information. It was a great presentation. And just remember that the code, and I can't see it, Kathy, do you have it off the top of your head? Is what you'll need to redeem your CME credits. And there's a link that is in this WebEx invite you can click into, put your name in, and the number would be, Kathy?
44152 is the event ID.
All right. Well, thank you, everyone. Thank you again, Dr. Dar.
Thank you.
This was a great meeting.
Thank you.
Have a great day.
Too.
Bye.